Hi, my name's Deon York. I'm Director of Consumer Engagement at Tāhū, Hauora, the Health Quality and Safety Commission in New Zealand. At the conference, I'm going to be talking about the Code of Expectations for Health Entities Engagement with Consumers and whānau. The code is all about ensuring that perspectives of consumers and whānau are reflected in the design, delivery and evaluation of our health sector in New Zealand. And of course, it could have broader implications and interest for the audience in terms of how it could be applied in other jurisdictions as well. So that's essentially what I'm talking about at the conference.
Hello, everyone. My name is Ashfaq Chauhan, or Ash. I am a postdoctoral research fellow in the Centre for Health Systems and Safety Research at the Australian Institute of Health Innovation, based at Macquarie University. And at the conference, the PMG Quality Forum, I will be talking about how we did co-design with people from culturally linguistically diverse backgrounds and cancer clinicians, and developed an instrument called Making It Meaningful to improve the medication safety for people from culturally linguistically diverse backgrounds accessing cancer services in Australia.
Healthcare's really changed in recent years. So we sort of used to be happy to go to a healthcare practitioner and just say, give me the care that I need, give me the help that I need. But in recent years, we're sort of moving towards this model where consumers have much more of a role in what care that is they receive or how it's delivered and those sorts of things. I feel like there's lots of buzzwords in this space at the minute. There's co-creation, co-development, co-design, and PPI, consumer involvement, and it can get a bit confusing, really. So I wondered if you could just say a little bit about what that actually means in the real world.
If we start with co-design simply put is ensuring that people who are going to be using a service have a say in how that service might look in a healthcare context. So really it's just about getting everybody together, whether that's the clinical team, healthcare management, people involved or are going to access care, getting them all together right from the beginning all the way through to the end, and having those courageous conversations about what problem that we're really here to solve. It's really that simple. That's what co-design is. Yes, it's simple, but often it doesn't happen in a healthcare context.
No, I agree with you on co-design. Basically, simply put, is designing something with people who are affected by what the service is designed for, or they're going to use it. But again, there are various aspects of how, or various level at how people can be involved in the process. So it could be just a tokenistic approach where they're like, oh, you are here, or it could be a tick box exercise, or it could be a more meaningful and engaged approach that is the idea behind a co-design. But oftentimes there is that distinction need to be made. We need to be clear about that, how we are doing co-design or whatever we are designing or co-creating with other people, especially patients. We give them equal opportunity to participate in the process and not just as a tick box exercise, which I think is the crux of all core approaches, I suppose.
And could you both give me an example of when you've co-created care with consumers or service users?
We have many examples at Te Tāhū Hauora of projects which have involved patients, consumers, family and whānau. In the New Zealand context, of course, whānau being family. And even the talk at this forum about this code of expectations. This code of expectations, while it was a directive of government that it needed to be created, it was the approach that we took in creating that really is what matters. And so it's not just about what the clinical communities thought, it's also about what the patient communities thought and what the context of this code should be and how we should put it together. So that's one example, a more recent example of co-design, but there are many examples, I think, in Australasia of where services have been co-created.
I have been very lucky to involved in a project called Can Engage project, and my PhD was embedded within that project as well, and was lucky to involve in a way because one of the component of the project was to develop co-design interventions that would enhance safety for people from culturally linguistically diverse backgrounds or ethnic minority backgrounds. I think that's the term used in the UK more commonly, to improve delivery of safer care. As part of this project, we did some groundwork at the start to understand what were the safety events or the context of safety events that impact people who are from ethnic minority backgrounds, and to gain that understanding, and then took that understanding to then co-design with people what was the solution, what was the problem that mattered to them at that particular service. So we had 6 different cancer services as part of the project, and we are doing co-design independently at each of the service with consumers who attend those services, as well as clinicians who deliver services, care at those services. So we are just going very locally at the service level with consumers from one ethnic minority background to understand what is the problem from this plethora of problems, what is the main problem for them, what they would like to achieve, in what form it will take, and then how it needs to be implemented in the process of care so that it's not lost at the stage where it is designed, but then not implemented and evaluated the effectiveness for. So the presentation that I'm talking about at the Quality Forum is based at doing the co-design at one of the center. And as part of the co-design, we developed this instrument called Making It Meaningful. So groundwork to that was our research identified that there were lots of medication errors, medication-related issues for people who are from ethnic minority backgrounds, particularly accessing the cancer services. And when we interviewed patients and consumers and staff, we identified that often there was a lack of shared understanding around what are the instructions around medication management, or what are the instructions around care processes. And because of this lack of shared understandings, which was impacted by a range of factors, that lack of shared understanding often resulted in issues or patient safety events. So the consumers and staff focused on addressing one issue, which was they didn't know how to identify side effects of cancer medications. So what are the common side effects? And when to seek help if something happens, and who to contact if something happens. So these were the 2 questions: when to seek help and who to contact, that we identified to the co-design process. And then Making It Meaningful is a adapted medication discharge summary that addresses these 2 questions. So it has a list of common medication side effects in English as well as other language, and it gives you a very brief, clear information about who to contact if you experience these side effects, or if you experience these side effects, then to contact emergency. So 2 questions, very adapted medication discharge summary came out of this co-design, which we are trialing now at the cancer service to see how it is, to see if it is feasible, and then hopefully to gather some pilot data.
So you've given really good examples of where and how you have co-created care. Why is it important that we are involving patients more in the services we develop? Why should we care about it? And why is it important that we do that moving forward?
If we're really not involving people who access services, then the question I would ask is, what are we doing it for? Because we know that consumer engagement and health quality and safety improvements go hand in hand. There's plenty of evidence that engaging consumers leads to better health and care outcomes. It leads to enhanced service delivery and governance. It can lead to culture change within the health sector, mutual learning, and lower cost of care delivery. And I think what we're really interested in is we have a system that is really built on learned experience. It's built on technical expertise that's valued, highly skilled, and very important for the effective running of the health sector. But the lived experience also has a place. So it's really about finding that equilibrium between the lived experience and the learned experience. So if we, if we don't involve people, then again, what are we doing it for? I think the question is, why are people not being involved in decisions about their care? Why are they not being involved in creating a system that ultimately they may have to access at some point in their lives?
My area of work is working with people who are from ethnic minority backgrounds. So they are priority population groups who have poor health outcomes, from ranging from access to care to quality and safety outcomes. And one thing I'm very mindful of when we are working in the space of ethnic minority background is that there is considerable diversity within the group. So the approach that one size fits all approach doesn't apply to this very diverse group of people. And to understand this diversity, it is important to involve people to understand how different things impacts differently to different outcomes. I often think about my personal example, like my mom and I are completely different in our point of view, how we engage in healthcare or how we respond to when we have a conversation with doctors. So I will ask plenty of questions, but my mom probably won't ask any questions. So even like it's not just diversity within or in between the groups, but in within the groups as well, depending. So understanding the diversity, and I think involving consumers in their care really bring that what really matters to this particular group of people, and how we can address their issues that matters to them to achieve the outcomes that improve their overall health and reduce disparity.
And Deon, you touched on this briefly, but could you think specifically now about how does involving consumers in their care, how does that lead to better quality care?
We know that if you involve people in the quality improvement activities, you involve consumers in quality improvement activities, that you're going to have unique insights that can really drive and improve the system. It's going to offer sort of a different perspective to the staff as well, that are treating consumers. I think what you already heard as well, that creating a service that's more aligned to the needs of the person. So often simple questions or simple lines of questioning to consumers can lead to care that's not required as well as care that is required. I think it helps inform choice, it helps improve health. It also engages people with what services are available. And as you've also heard as well, it responds very much to local need. So, there's so many positive reasons why we should involve consumers, involve people in decisions of this nature about the health system. Again, I say, why would it not happen? And of course, it is happening in a lot of places. And you mentioned earlier about there being sort of a bit of a resurgence in it. I think it's been around for a long time. I think that, its origins really are in, mental health and addictions rights movements, disability rights movements, and other movements. So on one level, it's nothing new, but on another level, what we're seeing is, in some jurisdictions where we compare ourselves, this real kind of coming together of the importance of doing this now, the importance of being able to measure it and show its impact, because sometimes attribution's not that easy in this area. But intuitively, almost, it seems to make sense that if you want to know what people think, you need to ask them. That simple, really.
What would your top tips be for someone that wants to go about co-creating care?
Lead in time, resource appropriately, make sure that there's not just the one sole consumer voice in the room. In fact, that there is support around that, because we might be talking about redesigning a service, but we also might be re-traumatizing someone who's accessed a service and maybe not had as good an experience as what they should have had. So I think there's a lot of preparation that goes into doing this properly and doing this effectively. Yeah, there are many ways I think that it can be done well, but probably the way that it's done poorly, which is the biggest learning, is to make sure that support is there. I think you've got to really engage people all the way through. You do that for any good project. You'd make sure that people are well informed all the way through. Also have the courage to say when something won't fly and something won't work. I think the fear people have of involving consumers, involving patients, is they're going to want a gold-plated health service that's impossible to achieve. But quite often what the converse happens, and it's practical tips and ideas on how we can make improvements that don't necessarily cost more, could potentially release time to care for people as well. And so, be able to have those courageous conversations, involve people early, involve them often, create a safe environment for people, and just generally be open. That would be my advice.
What I learned from my co-design project was keeping my values aligned with the principles of co-design. Easy said, but it's you have to constantly reflect on it. What are your values? How you're doing that, and how they are aligned with the values of the co-design. So reflecting onto that during the process is a good tips to make sure that you are engaging consumers in a way that there is an equal power distribution in how decisions are made. There is an equal contribution to the level that they want to be involved in the research process. So those things are important. Openness, as Deon said, in my context, it was giving equal chance to everybody. For example, when we went into this co-design process, we created this a network of consumer co-facilitators. So we train them in how to do co-design research, provide them training relevant to the project, and asked one of them to become a co-facilitator along with the research to conduct the research, so that the researchers can learn from them during the process, and the process doesn't become researcher heavy then. So there is a input from a consumer in that research process as well. I think what the resources, identifying the resources and delivering on them. So do they need taxi vouchers? Do they need travel arrangements to be made? Because when we're talking about engagement, we need to we do this as part of our job, but often consumers are doing this on top of their job, on top of their commitments to other things, taking care of the person who is sick at home, or they might have a baby. So we need to consider those things and address those things if we want an equal level of participation from them.
Now, both of you are presenting at the Quality 2023 conference, which is coming up in Melbourne in October. You're both presenting in the Patient Safety and Co-Creating Care with Service Users stream. So Deon, you're going to be presenting on a national code of expectations for consumer engagement, and Ash, you're presenting on co-designing a medication and safety intervention with service users. So I want you to imagine that you've just caught someone in an elevator. You're going up to your talk. You've got about 20 seconds to describe to them why it's absolutely crucial that they come along and listen to your presentation at the Quality Conference. So Deon, up to you.
I mean, the crux of it is, how can a code really improve how the health sector engages with the people it serves? And what I really want to demonstrate is how something like this was developed, how we managed to get all of these concepts that we've been discussing here and beyond onto 2 pages, and what the implications are for driving that forward, and hopefully help some other places think about how they can do that, because we have a health sector where information needs to be delivered concisely and clearly in order for there to be any sort of change. So for every concept that is on that 2-page, there's a lot of implementation that sits behind that. So I'd encourage people to come along and hear about that and some practical tips about how they might apply it locally.
Brilliant. And Ash, why should people come to your presentation?
When we knew that medication safety event is an issue, but I didn't know that it's just not having this real understanding of what are the side effects of the medication, how they look like, and who to contact could potentially lead to unwanted emergency presentations. So if you want to learn about how to avoid that or how to mitigate that, come and listen to my talk that we have developed a co-design intervention with patients and clinicians from One Cancer Service to address this particular issue.
Thank you both so much. It's been really interesting chatting with you both about all things co-creation.